Well, good afternoon, everyone. This is Sylvia Silver. I'm one of the co-directors of the Developmental Corps and actually have been trying to reinvigorate our HIV malignancy interest group, which we have the honor today of having Meredith Shiels present. Dr. Shiels earned her MHS and PhD in cancer epidemiology from the Johns Hopkins Bloomberg School of Public Health, and she joined the Infectious and Immunoepidemiology Branch as a Cancer Research Training Award postdoctoral fellow at NCI in 2009. She was awarded the Sally Rosen-Kaplan Fellowship for Women Scientists in Career Research that same year. And in 2016, she became a tenure-track investigator at NCI. Meredith, thank you and welcome. And you are going to present today for us for the HIV Malignancy Interest Group and the CFAR.
Great. Thank you so much, Sylvia, and thank you to everybody for joining us today. I welcome the opportunity to present on shifting trends in cancer risk and burden among people living with HIV in the United States. So to begin my talk today, I'm going to give a brief overview of cancer risks in people with HIV. I'm going to talk a little bit about cancer rates among HIV-infected people in Washington, D.C. I'm going to highlight the risk of specific non-AIDS-defining cancers and their associations with immune suppression. And then I'm going to finish up by describing shifting cancer incidence rates and burden over time in the U.S. HIV-infected population. So starting with an overview of cancer risk in people with HIV in the United States. As this group well knows, the risk of certain cancers is elevated among HIV-infected people. This group includes 3 AIDS-defining cancers: Kaposi sarcoma, non-Hodgkin lymphoma, and cervical cancer. This figure shows the standardized incidence ratio or relative risk of each of these cancer sites relative to the general population. So if you look at the estimate for KS, for example, this shows that rates of KS are roughly 500 times greater amongst those with HIV than the general population. For NHL, it's around 10-fold, and for cervical cancer, it's about a 3-fold increase. Rates of other cancers considered to be non-AIDS defining cancers also can be elevated amongst those with HIV. And this list is not exhaustive, but it's often one that we use as these are more common non-AIDS defining cancers. So anal cancer rates are elevated over 10-fold. The elevation for oral cavity and pharynx cancer is more attenuated. Liver cancer, Hodgkin lymphoma, and lung cancer are all elevated amongst those with HIV infection. One thing that many of these cancers have in common is that many of these sites are associated with co-infection with other viruses. So KSHV, Epstein-Barr virus, human papillomavirus, and hepatitis B and C virus are all associated with some of these cancer sites here. And one of the outliers is lung cancer, which is the rates are elevated between 1.5 and 2-fold among HIV-infected people. But lung cancer is not known to be associated with any co-infection. So we'll talk a little bit more about some of these cancer sites later in my talk. It's important to note, though, that not all cancers occur at an elevated rate among people who are HIV infected. So, for example, prostate, breast, and colon cancer, which of course are 3 of the most common cancer sites in the general U.S. population, actually occur at a reduced rate among HIV infected people, and that's something else I'll touch on a bit later. So effective antiretroviral therapy, or ART, was introduced to treat HIV infection in 1996. ART suppresses viral replication and reduces immune suppression, and it reduced the risk of death increased life expectancy and thus resulted in an aging of the HIV-infected population in the United States. It also reduced the risk of AIDS and AIDS-defining cancers. Most notably, rates of KS and NHL declined dramatically in the ART era. So I'm going to start with the data presentation part of my talk today by talking about cancer rates among people living with HIV in Washington, D.C. Sylvia asked me to include this because, of course, it's probably of very keen interest to those of you who study HIV in the Washington, D.C. area. So most of the results I'm going to show you today are from the HIV/AIDS Cancer Match Study, and this is a study that I am the PI of along with Dr. Eric Engels, whom many of you are probably familiar with. This study includes data from a number of states in the country, as well as Washington, D.C. and Puerto Rico. This study is a ever-evolving study in that we do a number of linkages a year, and so we're constantly updating our data. And we had the pleasure of adding Washington, D.C. just about a month ago to our overall data set. So you can see that Washington, D.C., we have data on people living with HIV between 2007 and 2015, 33,500 people. And amongst those people living with HIV, 856 cancers occurred. If you're interested in what the most common cancer sites are, again, these are the cancers that we often highlight, though this list is not exhaustive. But amongst those 856 cancers, the most common were non-Hodgkin lymphomas, lung cancer, and prostate cancers, followed by Kaposi sarcoma. There are roughly equivalent numbers of anal cancers, liver cancer, Hodgkin lymphoma, colorectal cancer, and breast cancer, and there were 19 cervical cancers. You may be interested in how the rates of these cancers compare to the overall HIV/AIDS cancer match study. You can see here these are crude incidence rates in the overall study in blue and in the DC linkage in red. You can see that rates in DC of Kaposi sarcoma and non-Hodgkin lymphoma were somewhat lower, and rates of cervical cancer and prostate and breast cancer were somewhat higher than the overall study. Rates of anal cancer were also somewhat lower. I missed that one there. You may also be curious as to what the relative risk for these cancer sites is in DC. So this would be, again, estimating a standardized incidence ratio, which compares rates amongst people living with HIV in Washington, D.C. to the general population of Washington, D.C. after accounting for age, sex, and race in calendar year. So in D.C., rates of Kaposi sarcoma are elevated 330-fold amongst people with HIV. You can see the SIRs for NHL and cervical cancer are 3.2 and 3.5. And you can see the remaining SIRs for these other non-AIDS defining cancer sites. And of note, we also see this deficit for colorectal, prostate, and breast cancer, which is consistent with what we've reported before. And in comparing DC to the overall HIV/AIDS cancer match study, the SIRs are somewhat lower for NHL, anal cancer, liver cancer, and Hodgkin lymphoma. So now I'm going to talk about the risk of a handful of non-AIDS defining cancers and their associations with immunosuppression, just to give a bit of an overview of what is known. So starting with anal cancer, as you all know, anal cancer is an important cancer site amongst HIV-infected people. It's elevated strongly in this population. Anal cancer predominantly occurs among men who have sex with men. So that's a little bit of what's responsible for the elevated rate in the HIV-infected population, but it's also important to note that even amongst even amongst men who have sex with men, HIV increases the risk of developing anal cancer substantially, and that's been shown in the MAX cohort which is a cohort of men who have sex with men with and without HIV infection. Anal cancer is primarily caused by HPV, and immune suppression is associated with increased risk. So you can see this figure on the slide to the right, which is from the Kaiser cohort. You can see that relative to a CD4 cell count of less than 200, increasing CD4 cell counts reduces the risk of developing an anal cancer among HIV-infected people. Immune suppression is associated with increased HPV prevalence of the anus and also potentially associated with HPV persistence. Using data from the HIV/AIDS Cancer Match study, we recently estimated the probability of developing an anal cancer in people with HIV. Just pulling a selection of results from that study, if you look at 45 to 59-year-olds, this first figure here, the yellow line is the cumulative incidence for men who have sex with men, the blue line is for women, and the gray line is for other males. So at 10 years, the cumulative incidence of developing anal cancer 10 years after HIV report is 0.7% in men who have sex with men, 0.13% in women, and 0.15% in other males. If you look at people who have had an AIDS diagnosis and start estimating cumulative incidence from AIDS diagnosis, among men who have sex with men, the cumulative incidence is much higher at 1.1%. Among women, it's 0.3%, and among other men, it's 0.2%. The standardized incidence ratio or relative risk of anal cancer among people with HIV relative to the general population has declined significantly over time, most notably since about 2000, 2001. You can see that the SIR has declined, though it remains strongly elevated compared to the general population. I'm now going to talk a little bit about liver cancer in people with HIV. Some liver cancers are caused by hepatitis B and hepatitis C viruses. Alcohol, of course, also increases risk, and we have seen that the highest risk for liver cancer is among HIV-infected injection drug users. And injection drug users, part of the reason they have such a high rate is because of co-infection with hepatitis C virus. Studies have shown that immune suppression is associated with increased risk. These data are from a French study, and you can see that this figure is set up in the opposite way of the last one that I showed you. So here, the reference group is the least immune suppressed group, and with increasing immune suppression, therefore declining CD4 cell count, you see an increased rate ratio of developing liver cancer. A study also just looked among those who have less immune suppression, so those with CD4 cell counts of sustained CD4 cell counts of above 500. And they observed, again, this is in a French study, that liver cancer rates were still elevated twofold, which speaks to not only is there a role of immunosuppression, but there are other factors, most likely a co-infection with hepatitis C, for example, that are increasing rates of liver cancer in this population. Like anal cancer, we see a decline in the SIR of liver cancer over time, and currently the SIR is roughly just shy of 3, so 3 times higher than the general population. Lung cancer, as I mentioned earlier, is really an outlier in that there's no known infectious cause of lung cancer, so it doesn't fit the paradigm of virus-associated cancers being elevated in people with HIV. Of course, many of these SIR calculations do not take into account smoking. And we know that the prevalence of smoking among HIV-infected people is very high. The estimates vary, particularly between risk groups with injection drug users having an incredibly high prevalence of cigarette smoking and MSM having a lower prevalence. But regardless, the prevalence of smoking amongst HIV-infected people is quite high. But cohort studies that have looked at the risk of lung cancer after taking smoking into account still see elevated rates of lung cancer among HIV-infected people. And the studies have really been varied in terms of association with immune suppression. Some have not found associations while others have. The results I'm showing you here is, of course, from a study that did find an association between CD4 cell count and lung cancer, with increasing rates amongst those with more immune suppression. An updated version of this French study showed that amongst those who have higher CD4 cell counts of more than 500 that are sustained for a period of time, there's no elevated rate of lung cancer, again, providing some evidence for a role of immune suppression. Like the other cancer sites I've shown you, lung cancer SIRs have declined over time. This could be due to improvements in more treatment with ART, or could be, and it could also, if there are changes in smoking behaviors over that time period, that would also influence these results. So what are the hypotheses for increased lung cancer risk? I've already told you that it's unlikely to be infection-related. I don't know why this says 1-2-1, but first, it's been hypothesized that there's remaining residual confounding by tobacco use. We do our best to adjust for smoking in cohort studies of HIV and lung cancer, but of course, some effect of smoking may remain. HIV-related pulmonary infections is a potential hypothesis, and this has been addressed in several studies. The VA has looked at this. Kaiser and the Maxim Wise have looked at this and shown associations between AIDS-related pneumonia as well as recurrent pneumonia, and shown associations with lung cancer risk. So this has to do with a hypothesis of inflammation due to recurrent pulmonary infections, perhaps driving the lung cancer risk among HIV-infected people. And third, not first, potentially increased susceptibility to tobacco carcinogens, though this hypothesis has not been well vetted in the literature. I'm now going to take a brief look at these anomalies, prostate, breast, and colon cancer, that actually occur at reduced risks among people with HIV infection. So one potential explanation for reduced rates of these three cancers is that these cancers are all screen detected. If there is more screening in the general population than in the HIV-infected population, this would result in more diagnoses, of course, because more screening would result in more cancer diagnoses that have not been clinically detected yet, and also a shift towards smaller early-stage disease. So screening catches disease early, and so we would expect there to be more smaller early-stage disease if this is a screening effect in the general population. So therefore, a screening effect would be consistent with a larger deficit in the incidence rates in smaller early-stage cancers, and perhaps no deficit for larger late-stage cancers that are less likely to be screen detected. They're more likely to be clinically detected. So what we did is we used data from the HIV/AIDS Cancer Match study, and we looked at standardized incidence ratios by stage and size for these cancer sites. So with the exception of distant stage, so to orient you to this figure, the cancer sites are here on the left, followed by the stage, and then the standardized incidence ratios on the x-axis. With the exception of distant stage breast cancer, where there was no reduced rate, across stages for breast, prostate, proximal colon, and distal colon cancers, we saw deficits in HIV-infected people compared to the general population. When we looked at tumor size for breast, proximal colon, and distal colon, we saw consistently reduced SIRs across tumor sizes. And what this says to me is that we're not seeing the pattern that we would expect that would be consistent with differential screening driving these reduced rates. So there may be a true biological effect that's somehow resulting in lower rates of these cancer sites among people with HIV. I can't offer a very satisfying biological explanation, but this is certainly an area that needs more investigation. I'm now going to shift gears a little bit away from talking about individual cancer sites to giving a big picture of the shifting cancer incidence rates and burden in the HIV-infected population over time. So I'd already mentioned that in the ART era, rates of Kaposi sarcoma and NHL have declined dramatically. So these are standardized incidence ratios again. You can see that in 1996, ART was introduced, and there was a very sharp decline in both KS and DLBCL, followed by a sustained, more subtle, well, still pretty pronounced, but a sustained decline thereafter. So the SIRs for these cancer sites continued to decline. We know that rates of many cancers have changed over time, largely attributed to effective ART. And in addition to KS and NHL, which I've just shown you, rates of other cancer sites have also declined. And I showed you a little bit of that earlier with the SIRs for the cancers that I highlighted. And cancer burden has also shifted over time. And when I talk about cancer burden, I mean the annual number of new cases of cancer that are diagnosed amongst HIV-infected populations. So we need to think about what impacts cancer burden. So first, how frequently does cancer occur? And that is incidence rate. So of course, if you have increasing incidence rates, that will result in more cancer cases. If you have decreasing incidence rates over time, that will result in fewer cancer cases. And another important component is how many people are living with HIV. Clearly, if there are more people there are, the more cancer cases there will be in the U.S. And finally, who is living with HIV? And when I say who, most importantly, I mean there are more older people in the HIV-infected population. As we all know, cancer risk generally increases with increasing age. So as there are more people who are older in the HIV-infected population, we would expect to see more cancer cases. So this figure shows the total number of people living with AIDS in the U.S. from 1980 to 2013. I show you this because you can see that the total number of people living with AIDS has increased dramatically over time, and that increase is predominantly concentrated in this green, yellow, and orange parts of these bars, which are people aged 40 and over. So you can see that the AIDS population increased dramatically, and also that there are now much larger number of people living with AIDS in the U.S. There are a much larger number of older people living with AIDS in the U.S. The reason I used AIDS to demonstrate the aging of the population is because the CDC only has national data for HIV going back to 2008. Whereas AIDS has been a registered condition since the beginning of the epidemic, essentially. So I'm going to start by showing you a study that we published a number of years ago now that estimated the cancer burden in the U.S. AIDS population from 1991 through 2005. And the way that we carried out the study was to estimate cancer incidence in people with AIDS in the HIV/AIDS Cancer Match Study. Again, this was when our study was largely comprised of people with AIDS. Now our study has both people with HIV with and without AIDS. And we combined our data with the CDC's AIDS surveillance data, which estimates the number of people living with AIDS in the U.S. And based on that, we estimated the total cancer burden in the U.S. AIDS population between 1980 and 2005. So these figures represent the total estimated number of cases of Kaposi sarcoma and non-Hodgkin lymphoma diagnosed in each calendar year between 1991 and 2005. You can see that the total number of cases of Kaposi sarcoma diagnosed declined rapidly in the mid-1990s, and it remains somewhat stable, it looks like, in the latter part of this time period here. And we see something similar for non-Hodgkin lymphoma, where total number of cases started to decline in the mid-1990s. Now, these declines are largely due to those very profound decreases in the incidence rates of these cancers that I showed you previously. If you add up the total number of AIDS-defining cancers in the U.S. AIDS population over this time period, you can see, similar to what's seen for KS and NHL, a sharp decline in the total number of AIDS-defining cancers diagnosed. At the same time, if you look at the red part of these bars, these are the number of non-AIDS defining cancers. We have seen an increase in the number of non-AIDS defining cancers over that same time period. And we estimated that starting in 2002, there were more non-AIDS defining cancers than AIDS defining cancers diagnosed in the U.S. AIDS population. So a real shift in what was observed in cancer diagnoses in that population. Just to show you that the total number of non-AIDS defining cancers for all of the cancer sites increased over time. So I'm just showing you anal cancer, lung cancer, and breast cancer. And it's important to note that it's not just those cancers that are associated with HIV infection, but also breast cancer that's not associated with HIV infection. We see an increased number of cases, and these increases are largely driven by the growth and aging of the U.S. AIDS population. So more people, more older people will result in more cases of non-AIDS defining cancers. So as I said, that paper was published a number of years ago, and so recently I wanted to understand what the future looks like for this population. So it's a very dynamic population in terms of the demographics of the population changing, and I wanted to know what the future cancer incidence rates and burden would look like in people with HIV in the United States. So as I just mentioned, the demographics of the U.S. HIV population continue to shift due to increased life expectancy. And the incidence rates of several cancer sites are expected to continue to decline based on current trends. So I thought it would be important to have estimates of future cancer rates and burden to inform prioritization of cancer prevention, early detection, and treatment. So this study was designed very similarly to the last study that I showed you. This time, however, the HIV/AIDS Cancer Match Study was not restricted to people with AIDS. This is people with HIV with and without AIDS. We estimated trends in cancer incidence rates between 2000 and 2012. And then, assuming that the trends in these rates would continue into the future, we projected cancer incidence rates from 2013 to 30. We worked with our partners at CDC, who we would collaborate very closely with, led by Dr. Irene Hall. And we used their model, the HIV Optimization and Prevention Economics Model, or HOPE model, to estimate and project the number of people living with HIV from 2006 to 2030. And then very similarly to what I did in my prior paper that I showed you, we estimated and projected cancer burden from 2006 to 2030. So this set of figures shows you the observed and projected cancer incidence rates for AIDS-defining cancers, non-AIDS defining cancers with elevated rates, and non-AIDS defining cancers without elevated rates in people living with HIV. So first, if you look at the AIDS-defining cancer figure, you can see that our observed data, which are to the left of this dashed line, we saw declines in NHL, KS, and also cervical cancer. And you can see to the right of this dashed line that the rates are projected to continue to decline. For non-AIDS defining cancers with elevated rates among people living with HIV, we're projecting that lung cancer, anal cancer, and Hodgkin lymphoma rates will continue to decline, while liver cancer and oral cavity and pharynx cancers will remain relatively stable. And for non-AIDS defining cancers without elevated rates in people living with HIV, we're projecting flat rates for breast and colon cancer, increasing rates for prostate cancer, and declines for all other cancer sites combined. This figure shows the estimated and projected U.S. adult HIV population from 2006 to 2030 based on the CDC's HOPE model. You can see that the total number of people was projected to increase through 2018, followed by declines. And this also resulted in a notable shift towards older ages. So in 2010, 39% of the HIV-infected population was aged 45 to 64, and about 9% was aged 65 and older. And that will shift further towards older ages to 48% of HIV-infected people in 2030 being aged 45 to 64, and 21% being age 65 and older. So you can see that the CDC is projecting a really notable shift towards older ages in this population as people live longer with effective treatment. When we apply those estimates together, we estimated the cancer burden in the U.S. HIV population by site. So you can see that in 2010, we estimated roughly 8,000 cancer cases in the U.S. population, in the U.S. HIV population, and that the most common of these cancers were NHL, followed by KS, and lung cancer. You can see, based on the key here, the other cancers that follow, prostate, anal cancer, and liver. In 2020, we see a somewhat decline in the total number of cases, and a shift with prostate cancer becoming the most common, followed by lung and non-Hodgkin lymphoma, followed by anal cancer and Kaposi sarcoma. And then we're projecting a further decline in the total number of cases, with prostate cancer again being the most common site, followed by lung cancer and then liver cancer, anal cancer, and non-Hodgkin lymphoma. And Kaposi sarcoma is down here at number 8 in 11. In number 8 in yellow here. The largest decreases are projected for NHL and KS, and that's largely driven by the projected declines in incidence rates in these cancer sites. And the largest increases are projected for prostate, lung, and liver cancers, and that is due to the aging of the HIV-infected population. So if recent trends continue, the incidence rates of many cancers are projected to continue to decline through 2030, most notably Kaposi sarcoma and non-Hodgkin lymphoma. The fraction of the cancer burden due to AIDS-defining cancers will decrease from 1/3 in 2010 to 11% in 2030. And the most common cancer sites are projected to shift from NHL and KS in 2010 to prostate and lung cancers in 2030. Though the number of cancers diagnosed among people with HIV in the U.S. is projected to decline, cancer will remain an important comorbidity, and continued cancer prevention efforts are needed, including, most importantly, increased access to effective HIV treatment, because this will play a critical role in reducing future cancer burden in people living with HIV. Much of the decline that we've seen, particularly for KS and NHL, is driven by effective treatment. So that's critical that that continues into the future. There are also a number of important cancer prevention strategies that need to be considered for this population. Smoking cessation is, of course, critical given the high burden of lung cancer in this population. Treatment for hepatitis C virus and hepatitis B virus would also be critical for this population given the high burden of these viruses and the high risk for liver cancer. And continued research into HPV vaccination. It will be still a number of years before the cohort of girls vaccinated 10 years ago will reach the age where they're at higher risk for cancer. And I know there is some research into HPV vaccination amongst those with HIV infection. And so that will be needed given the high burden of HPV-related cancers in this population. For cancer screening, general population screening guidelines should be considered in consultation with physicians treating HIV-infected people. And more research is needed on anal and lung cancer screening among people living with HIV. Effective screening for these cancer sites could have a notable impact in this population, but my understanding is that the research is still ongoing. I'd like to end here and acknowledge my collaborators. So Dr. Eric Engels is the co-PI of the HACM study. Much of the data presented today is from our study. MJ Horner is our study coordinator. I'd like to thank Drs. Anna Coghill and Raul Hernandez Ramirez, who were former fellows here, who worked on some of the data that I presented today. Irene Hall, who is our collaborator at CDC. Tim McNeil, who is our data manager, and our HIV and cancer registry partners. And of note, because I highlighted the DC data here, I want to particularly thank Adam Alston and Carrie Dorsey at the HIV surveillance in DC, and Alfreda Woods at the Cancer Registry for their collaboration. And I wanted to leave plenty of time for questions, so I'm going to go ahead and say thank you. And I'm not sure if there's a way for people to ask me questions, but if there is, I'm happy to answer any that you may have.
Thank you very much, Meredith. Yes, this is Sylvia. There are definitely, I believe, people can just make sure their phones aren't muted or their computers and ask you, but I really do thank you very much. And so let us open the webinar to questions. Anyone in our audience have a question for Meredith? Wow, everyone is shy or they don't know how to unmute. Wow. Meredith, you know, the question about, you know, the liver cancer, the lung cancers, you know, and thinking about just it's the general population, it's just more cancer cases, and therefore that's why we will see them, and HIV doesn't really have anything to do with it? Is that what you're really putting out there?
Do you mean in the projection?
Yes, in the projections.
So it's not that HIV doesn't have anything to do with it. So certainly we still see that the risk of developing a lung cancer and a liver cancer is still elevated in people with HIV. The reason that we're projecting, for lung cancer, for example, we're projecting that the rates will decline, but the total number of cases will actually increase, even though the rates are declining. And that's because the age-adjusted rates are declining. And the reason for that increase is because the population is aging, and of course, risk of lung cancer increases with increasing age. So, and with liver cancer, we're projecting a flat rate, but because the population of older people is growing, we're going to see more liver cancer cases. So I should have been clear about that. Age-adjusted rates for lung are declining, but the total number of cases will increase because of the shift towards older ages. And prostate cancer is not elevated in people with HIV, but we know that prostate cancer is incredibly common in older men. So as the HIV-infected population reaches those ages, we're going to see more cases.
I see. And is there any cultural difference in the presentations that you are expecting? I mean, do we see more in the non-Hispanic population or white non-Hispanic, or do we see more in the Hispanic of certain of these? I imagine for prostate we'd see more in African-American men than non-African-American men. Is that correct?
We have not looked specifically at racial differences in prostate cancer. We've done some work with racial differences in HPV-related cancers, focusing on the Hispanic population, but we haven't spent. I don't know off the top of my head what all of the comparisons within the HIV-infected population by race ethnicity are.
Are there any collaborations with other areas of the world? I mean, are there data available in, say, Sub-Saharan Africa?
So I think you hit on a good point. It's something I would personally like to expand to be a little more, internationally focused as well. But the types of analyses that we're able to do with our data are really difficult in Africa because a lot of most African countries don't have good cancer registries, for example. There are, some studies in some areas where they've done data linkages like ours. In Africa, Kaposi sarcoma and particularly cervical cancer, the rates are far elevated compared to what we see here in the United States. But the infrastructure doesn't seem to be quite there yet to be able to do this type of analysis, but there are some countries that have done data linkages and are able to describe which cancers occur at higher rates in those countries. I know our study coordinator, MJ Horner, for her dissertation work, did a data linkage in Malawi, for example. So there are some isolated countries that have done similar sort of linkages.
Is Brazil considered one country that you could possibly get data from?
So Eric has worked a little bit in Brazil. They've published a little bit on, I believe, cervical cancer and outcomes from cervical cancer. I have not been involved in that work, but I know that Eric Engels and Anna Coghill do have a collaboration with researchers in Brazil interested in HIV and cancer. Okay.
Well, does anyone else have anything they want to ask Meredith? I've been dominating. I'm sorry. I find it fascinating.
Hi, can you hear me?
Yes. Yes.
Hi, this is Blair Spence from Georgetown. Excellent talk. Thank you so much. I have two questions.
Sure.
So one was about the crude. I think you had a graph of the crude incidence rates of HIV, AIDS, and cancers, and it compared DC and U.S. population. And it looked like to me, and you may have answered this already, but it looked like to me, for the most part, everything was fairly similar, except with the exception of Kaposi's and non-Hodgkin's lymphoma. Are there big differences in the population of those living with HIV in DC with cancer related to, as compared to those in the U.S., or is there anything that accounts for these differences?
So the reason I made sure to emphasize that this is a crude, crude comparison is we haven't not delved. Generally, we don't. I know this group is particularly interested in the DC linkage, but we don't generally, spend a lot of time focusing on particular registries. So I don't have a lot of great insight into why these rates may be lower. Certainly, there could be differences in age, there could be differences in risk group, race, ethnicity, but I have not spent time really trying to understand those differences in this analysis. I'm sorry, I don't have much more insight into it than just than that, really.
And then I have one more question about the modeling that you did looking at projected cancer rates. And and I know that you talked with Sylvia about this just a minute ago, but you mentioned liver cancer is going to be basically at a flat rate is what the projection is. Do you think that holds true even with effective treatment for hepatitis C that we have now?
Yeah, I mean, that is an excellent point. I hope that's not true. So the assumptions of our model were that the trends that we've observed continue. And it doesn't take into account, new positive or negative events that could shift the rates one way or another. And this is, I didn't get into it in great detail here, but in the paper, I do discuss that, effective DAAs for treating hepatitis C virus may be able to shift that curve, and that would be wonderful. So that would mean that our estimates for liver cancer are actually overestimates of the number of cases, which, of course, we hope that ends up being the case.
Thank you.
That's very interesting. Anyone else have a question for Meredith?
Well, if anybody thinks of any, sorry, go ahead.
No, I just wanted to thank you again, but I also wanted to invite any people that are on this call that haven't joined us in the HIV interest group for malignancy. We will be having a call a week from today. Isn't that correct, Aaliyah?
Yeah, it's next Wednesday at 10 a.m.
10 a.m. And we can have information sent to anyone on how to join us on that call, and we please encourage people because as you can see, HIV and cancer in our HIV population is going to be something that's going to be with us for quite some time, hopefully with the number of people still being able to live with their infection and, of course, still aging. And we all know that the 70s and 80s are the best times of life, evidently. So we will hope that we can conquer or help or treat. And then again, too, Meredith, thank you for the time and effort. Aaliyah, thank you for putting this all together. If there are no further questions, I will have us sign off.
Thank you very much.
One last call. Thank you again, Meredith. One last call for anyone?
Nope.
All right. Thank you, everyone.
Take care.
Thank you. Bye.